Hello, and welcome to the dilemma of when to stop disease-modifying therapy in MS. At this time, all participants are in a listen-only mode. If anyone should require operator assistance, please press *0 on your telephone keypad. A question and answer session will follow the formal presentation. You may ask a question at any time by typing it into the Ask a Question feature on the left side of your screen. As a reminder, this conference is being recorded. It's now my pleasure to turn the call over to your host, June Halper. June, please go ahead.
Thanks, Kevin. Thanks so much. Hi, welcome, everybody. Some of you who don't know me, I'm June Halper. I'm a nurse practitioner and CEO of the CMSC and the IOMSN. And this program is based on your request. You, our members and our supporters and our colleagues have asked us to do a journal club, so I'm pleased tonight to introduce to you two wonderful faculty who have chosen an article which I think is extremely relevant in today's MS world. I don't say it's relevant in the rest of our world, but it certainly is something very important. So it's my pleasure to turn the microphone over to John Kramer. John Kramer is a PA. He practices at St. Thomas Medical Partners down in Nashville, Tennessee. And his colleague, Bryan Walker, also a PA who's at Duke University. And I hope everything's safe down there, Bryan. We were all having a rocky year this year. I just want to say these two gentlemen are the co-chairs of our MS Special Interest Group for Physician Assistants, or PAs, those of you who don't know, PAs is the correct terminology. And we are doing this based on your requests, so feel free to ask questions, make suggestions, and stay with us for a wonderful and exciting program. Let me turn it over to our team.
Great, June. Thank you so much. And just want to say welcome to everyone. Thank you for taking some time out of your busy evening. And also special thanks to June and her team for supporting yet another edition of this journal club. And so when we first rolled out this journal club concept last year, I think we had around 20 or 30 participants. And tonight we've had over 180 people registered. So clearly there's been some strong interest in these journal clubs over the past several sessions. So that's great. As June mentioned, Bryan Walker is also on the line, and he'll be playing the role of color commentary as we move through these slides, and also keeping an eye on questions coming into the chat box. We'll also have some time at the end. We'll open up the phone lines for verbal Q&A as well. So this program is a CME program offering 1 hour of CME credit for physicians, for nurses, and also for pharmacists, PAs, and NPs and nurses as well. So this is the title of the paper, and as June mentioned, this is a really topical question in this new treatment era of multiple sclerosis. So when should we consider stopping disease-modifying therapy in a given patient? And before we move into the paper, I thought I would just take a step back and look at where we've come as it relates to prescribing DMTs. And you see on this slide the treatment considerations that were developed in partnership with the MS Coalition, of which CMSC is a strong partner of. And you see here that for patients that are diagnosed, they should be started on a disease-modifying therapy approved by the FDA as soon as possible following the diagnosis of relapsing MS, regardless of age. And relapsing MS does include, of course, now clinically isolated syndrome, people who've had a first clinical demyelinating event, and MRI features consistent with MS when other causes have been excluded. Of course, relapsing, remitting multiple sclerosis, and also active secondary progressive MS with clinical relapses or inflammatory activity on MRI. And this type of verbiage is now featured in the majority of the disease-modifying therapies that we use on a daily basis. And then for individuals with primary progressive MS, an agent should be used that is approved by the FDA for this phenotype. And so I think that the guidelines as are laid out here by the MS Coalition are quite clear and evident here in 2020. But it wasn't always this way. And thinking back, for those of you who've been in the field for some time, I mean, I can remember in the early 2000s, we had the ABCR drugs, or the CRAB drugs, as some people call them, and a lot of those studies were based on the Poser criteria. And so those treatment decisions at the time were all based on clinical outcomes. And so it wasn't uncommon for providers at that time to wait until the second attack occurred, the third attack, the fourth attack. It wasn't quite clear as to when treatment initiation would make a difference. And now, of course, over the past 20 years, we've learned that earlier initiation, and in particular with the advent of the McDonald criteria in 2001 and subsequent iterations, we've gotten better at treating patients earlier and hopefully bending that curve of disability over time in patient populations with MS. And so I tee it up this way because we didn't really have a clear understanding of how to treat this disease 20, 25 years ago. And now on the backside, we're starting to try and learn about this dilemma of when to stop disease-modifying therapies in MS. So the objectives of the paper were laid out in the following fashion. The authors wanted to conduct a narrative review of original research and practice guideline recommendations on the discontinuation of DMTs. They also wanted to present ethical considerations that were applicable to such decision-making. And finally, they were going to also look at collecting information regarding Canadian regional reimbursement policies for DMT coverage in MS, which we'll touch on briefly in the later slides. So as far as the methods are concerned, they did a narrative review of studies and practice guideline recommendations on the discontinuation of DMTs. And they did what would look like a traditional literature search: Medline, PubMed, OneFile, Scopus, ProQuest, Biological Sciences Collection, and of course the ever-present Google search bar to come up with various papers and clinical practice guidelines that discussed this topic of discontinuation of disease-modifying therapy in MS. And so this slide talks about the eligibility criteria. So the inclusion criteria were randomized controlled trials, observational studies, practice guidelines, or expert opinion practice recommendations that were published in the past 15 years. And the exclusion criteria were individual case reports, case series with less than 10 cases, and studies conducted in patients under the age of 18 or pediatric patients. And I think you probably already realize that there aren't going to be very many randomized trials as it relates to this topic due to myriad reasons, of course, including funding and the like. But if you look at the next slide, this is figure 1 from the paper, and this is the data extraction and synthesis. So looking at studies and guidelines that were identified through the database searching, they came up with over 4,400 different studies, papers, and guidelines. And then an additional Google search came up with 815 hits. So we're talking about 5,200 and change here. And about half of those, a little more than half of those, were considered duplicates, so those were removed. And then based on the exclusion criteria as we talked about, studies and guidelines that were not related to discontinuation of DMTs in MS, case reports or case series less than 10 patients, pediatric patient cases, any publications before 2003, or any full text that was not available online in the English language. And so now we're down to 112 studies and guidelines that were assessed, and with the inclusion criteria, the N here is 22. So this is the most rich data set that we have to look at when it comes to thinking about this dilemma of discontinuation of disease-modifying therapies. Not a lot of data out there, and more to come in the future. So the authors first looked at discontinuation of first-line disease-modifying therapies, and they were able to identify 4 studies. 2 were in relapsing MS patients, 1 was a secondary progressive MS patient population, and then 1 was an unspecified MS phenotype, a mixture likely of relapsing MS and secondary progressive MS.
And John, this is Bryan. So
yeah.
just to sort of pause, I mean, I know that there are many people on the line who are comfortable with thinking about DMTs structured as first line and second line. You know, there's sort of a historical perspective of that. I know that there are some folks out there who have a little bit more of an aggressive treatment paradigm, and they don't really think of first or second line necessarily. They might think about efficacy and try to match the right drug for the right patient at the right time. But with regard to how they're defining first line DMTs, could you just comment a little bit about what they're considering first and second line DMTs?
Absolutely. No, it's a great point, Bryan. Thanks. So the topic of this first line DMTs is going to be solely related to the injectable drugs interferon and glutamate acetate. And then for the second-line therapies, the studies that they were able to identify, which we'll see later, were all related actually to natalizumab.
Thanks, John. You know, again, I think that there are some of us who would just say, well, you know, in a treatment-naive patient, I might be aggressive right out the gate and use something that's considered to be a little bit more higher efficacious. But for these studies, their definition for first line were the older injectables.
That's correct. Yep. Yep. And so this first patient cohort was a Polish patient cohort of 43 patients. And that's going to be a familiar theme you're going to see with these studies, that even though the cohorts had to have at least 10 or greater number of patients, the numbers are going to be necessarily much smaller than what we're used to seeing in randomized phase 3 controlled clinical studies now in MS. And so this cohort was a group of patients that were treated with interferon beta therapy. And it's interesting that the patients were discontinued based on the fact that reimbursement for the drug was good for only 24 months. So regardless of patient desire or clinician desire to continue therapy, they were only allowed to be on treatment for 2 years. And so in this 43 patient cohort, 2/3 of the patients had a return to pre-treatment annualized relapse rate, and there was significant increase in disability progression 2 years after drug discontinuation compared to 2 years on treatment. Again, highly statistically significant p-value you see here. Clearly in this cohort, drug discontinuation in a relapsing population of 43 patients led to poor outcomes 2 years later. And the second relapsing MS paper that was looked at was a discontinuation first-line DMT Austrian cohort with 2 years of follow-up. And a multivariate analysis was performed and showed that the combination of an age greater than 45 years old and the absence of relapses over the past 4 years was the strongest predictor of relapse. And you can see here the hazard ratio of 0.06, quite low. So number significantly lower than 1 means that these patients had a significantly lower risk of having a relapse after discontinuation of therapy. And that's going to be another common theme you're going to see with a number of these studies, that the older the patient, the less clinical activity in the past, say, 3 to 5 years, tended to lead to patients not having significant recrudescence of disease activity over time. And you look here too, that there's actually a lower risk of disability progression seen in this cohort with drug discontinuation, but that was not statistically significant compared to the cohort of patients that were continued on therapy.
Just as a personal social commentary, I really don't think that 45 is older.
Well, that's my, I would completely agree with that. We'll call them middle age, Brian. So this next study was looking at, again, discontinuation of first-line disease-modifying therapies in a French cohort of 100 secondary progressive MS patients. And these were consecutive patients who had made a decision to discontinue disease-modifying therapy. And the annualized relapse rate for these patients 1 and 3 years after discontinuation was actually similar to the group that continued. The presence of gadolinium-enhancing lesions within 3 years of discontinuation was the strongest predictor of disease activity with a p-value of 0.004. And I think that this highlights the concept that perhaps these, what we would now call an active SPMS patient, at least they had activity 3 years ago, these are patients that might still have a therapeutic benefit from disease-modifying therapy. There was no consequence on the percentage of patients with disability progression when looking at EDSS before and after treatment discontinuation. And also, it was interesting that the treatment discontinuation at EDSS of 6 or greater was associated with a lower risk of relapse or MRI activity after discontinuation. Again, highlighting this concept I think many of us are very familiar and comfortable with, that at least at the macroscopic level, we're seeing burnout of new lesion formation, less or no formation of T2 lesions, gadolinium-enhancing lesions, and a lower risk of developing additional relapses once a patient hits a level of EDSS 6. And the largest cohort that was looked at was actually out of MS base, and this is the cohort where the subtype of MS was not specified. And so they categorized these patients as stoppers and stayers. So there were 485 patients that stopped disease-modifying therapy and 854 patients that stayed on therapy. And the patients who were stoppers had to be at least 18 years old, had to have at least 5 years since their last relapse, and follow-up was 3 years or greater after DMT discontinuation. The patients who were staying on disease-modifying therapy were required to have no relapses for at least 5 years at baseline, and were propensity score matched to stoppers for age, sex, and disability based on EDSS, disease duration, and time on treatment. And this propensity score matching is a nice way to estimate the effect of receiving treatment when randomization is not feasible. Obviously not in this case, as this is a real-world evidence observational-like study. And so the hazard ratio for early disability progression was 1.47 in the patients that stopped disease-modifying therapy, but time to first relapse and the annualized relapse rate were similar. And the researchers also determined that younger age and lower baseline disability were significant predictors of increased relapse risk in DMT stoppers. So it's, again, the opposite end of the spectrum was what we saw with this most recent study we looked at, that younger age, lower levels of disability, stopping disease-modifying therapy put these patients at increased risk of relapse upon discontinuation of disease-modifying therapy. So let's move on to the discontinuation of the second-line disease-modifying therapies. And so there were 6 studies that were looked at, 3 in relapsing MS, 2 in secondary progressive MS, and 1 in an unspecified MS phenotype. And as I mentioned earlier, all these studies that were designed were designed to look at natalizumab discontinuation to address the issue of increased disease activity or rebound effect, with rebound effect defined by the authors as an increase in disease activity above and beyond the baseline disease activity they had before initiating natalizumab. So I think what you'll see over these next slides is a bit of a mixed bag picture as well. And so this particular study, first one that was looked at with natalizumab was a phase 4 study over 12 months with 50 patients looked at. All patients had at least 24 or more infusions of natalizumab, and the reason for discontinuation was due to the patient and or clinician perceived risk of progressive multifocal leukoencephalopathy. So there were 2 arms, and there was an immediate discontinuation group versus a tapered group, with the tapering done as follows. There was a single infusion given 6 weeks after the most recent dose at 4 weeks, and then one final dose 8 weeks after the previous dose. So a 14-week taper overall compared to the patients that were in the immediate discontinuation group. And then all of these patients were placed on an alternative DMT at the discretion of the treating clinician. And what they found was that the immediate discontinuation group had a higher number of relapses compared to the tapered group. So 28 relapses versus 8 relapses. A statistically significant p-value here, with most of the relapse activity occurring in the first 3 months, with 21 relapses in the immediate discontinuation group and 7 in the tapered group. The immediate discontinuation group had a higher number of T2 lesions, T2 lesion volume, as well as new hypointense T1 lesions compared to the tapered group, and all of those MRI endpoints were considered statistically significant. And so the authors also wanted to look at the risk of disease rebound activity while on natalizumab. And again, mixed bag picture here. You see with the first study, this was a relapsing MS patient retrospective cohort study that was performed in Italy with 54 patients. And so prior to natalizumab treatment, the annualized relapse rate was 1.74 with an EDSS of 3. And then upon discontinuation, you see that the ARR is lower, near 1, and the EDSS had actually slightly improved for this cohort. And the authors felt that these results supported a low risk of rebound disease activity in this particular 54-patient cohort out of Italy. You see a different picture in a separate study. So this was also a retrospective cohort study of 132 patients in Italy, also at 2 MS centers. And so 95 patients were switched to another disease-modifying therapy after median natalizumab washout of 5 months. And of those 95 patients, more than half of them were switched to fingolimod. Disease reactivation, which was defined as either MRI and or relapse activity, occurred in 55% of patients, with 21% of patients meeting criteria for rebound disease activity. So 1 in 5 patients had evidence for rebound disease activity above and beyond their baseline disease activity prior to initiation of natalizumab. And the strongest predictor of relapse activity after natalizumab was discontinued was relapse activity in the 2 years prior to natalizumab initiation. Another paper that was analyzed was a single-center Italian prospective cohort with 110 patients. So all of these patients had at least 12 natalizumab infusions, and within 1 month, the patients were switched to either interferon beta, 18 patients, or Kramer acetate, 72 patients. And then within 3 to 6 months, patients were switched to either fingolimod, 10, or another 10 patients were not given any additional treatment. And so by 1 year, 75% of these patients had return of clinical activity, either radiographically or clinically in the form of relapses after discontinuation of natalizumab, and 10% of this cohort met the criteria for rebound disease activity. The time frame when this highest risk of return of disease activity or rebound activity occurred between months 2 to 8 after discontinuation. And similar to the recent paper we just looked at, is that the patients with a higher annualized relapse rate of 2 in the year prior to natalizumab initiation versus lower ARR 1.5 had greater risk of relapses upon discontinuation. This was also statistically significant. And then year 1 after discontinuation, the EDSS rose from 2 to 3 for the cohort with also statistically significant p-value. Now this particular study was published in 2015, 2016 timeframe, so we've had some newer agents come onto the market. But Bryan, maybe you can speak to this concept of, where do you go after natalizumab, say, 2014, 15, 16. This was always a vexing issue because it didn't seem like we had good places to go after that.
Right, John, and there wasn't, and one of the studies looked at switch to fingolimod or restarting natalizumab versus no treatment, and what was the risk of relapse there, and again we're sort of looking at this from a different lens here in 2020, but at the time. There were 57 participants who switched to fingolimod with 23 that had a return to disease activity, meaning relapse or MRI changes. And so I think, how much of that now do we think about as, is that really a failure of fingolimod versus a rebound effect from natalizumab? And I don't know that, when that study was done, that was actually a concept that they could quantify or identify based on the time to switch and how long they were off natalizumab before switching to fingolimod. Because that was a concern also at one point was, well, do you wait and how long do you wait after discontinuing natalizumab before starting another DMT?
Yep, absolutely. And so this other study was a single prospective cohort in the United States, 84 patients, again, looking at discontinuation of natalizumab, mixed population in this case. So these patients relapsing forms of MS as well as secondary progressive MS. And all patients had received at least 12 doses of natalizumab. And 81% of this cohort had discontinued treatment. And of that 81%, 28% had experienced a relapse within 6 months of discontinuation. The continuous treatment group, interestingly, during this time had no relapses between months 12 through 18, so also statistically significant data here. And so this is the final study that was looked at. So this is a prospective cohort, also in the United States, of 77 SPMS patients who were advised to stop DMT because of the fact of 2 years of no relapses and no new lesion activity on MRI with a median age of 61. And there were also 17 relapsing MS patients who had made a personal decision to stop natalizumab. And so 9 patients, or 11% with SPMS, had disease rebound activity versus almost 60% of patients with relapsing MS. And it was interesting that the patients that were over the age of 70 had an approximate 90% probability of remaining relapse-free after drug discontinuation, with a median EDSS cohort for this group of 6. So again, mirroring what we saw earlier with the older patient cohorts with first-line DMT discontinuation in a setting of not having clinical or radiographic activity over a period of years. The paper does go into significant detail about various guidelines for DMT discontinuation. I'm only going to highlight the AAN guidelines, and I think a lot of us are members of the AAN. And so the language is pulled directly from the website. The clinician should advocate that people with MS who are stable, that is, no relapses, no disability progression, and stable imaging, who are on DMT, that they should continue their DMT unless the patient and physician decide that a trial off of therapy is warranted. And they also commented that clinicians may advise discontinuation of DMTs in patients with SPMS without ongoing relapses or gadolinium-enhanced lesions on MRI activity, and who are non-ambulatory as defined as EDSS 7 or greater for at least the past 2 years. I'm not going to belabor this slide. I think most of us on the line are probably in the United States, but I think this is an interesting slide in that the Canadian reimbursement policies are quite variable as it relates to the province that patients live in. And I think the general theme here is that these later SPMS patients, if you will, that would probably not qualify for standard EDSS entry criteria for an SPMS trial, at least the traditional ones, usually 3 to 6.5 on EDSS. These are quite clear in terms of their guidance as to what disease-modifying therapy can be used given the patient's level or number on EDSS. And so then the paper goes into
John.
this. Yeah, of course.
John, could I just stop you there for 1 second? I just thought that it was interesting, going back to that one particular slide with regard to cost. You know, certainly Canadians have access to universal health care and a national health care system, and you know, the cost is significantly impactful for any organization like that. But I thought that it was interesting that you know, when they did publish this policy, which was back in 2011, you know, they had a certain number of medications at that time, and you know, fingolimod was probably the most expensive that they had in their armamentarium in 2011, and so they came out with this recommendation about stopping disease-modifying therapies based on this reimbursement policy and cost, and they actually came up with this recommendation that they didn't have any specific practice guidelines for stopping DMTs in MS, with the exception of fingolimod, and it was based solely on cost, and it was around you know, their theory of that continued use of an expensive agent is considered unwarranted in the absence of any substantial sustained clinical benefit. But they didn't, you know, how do you you know, define substantial sustained clinical benefit with a disease-modifying therapy? You know, I mean, really, the name of the game is to maintain, and you know, we're trying to keep people in a functional capacity for as long as we possibly can, and the goal is to not have them progress. Unfortunately, nothing in our toolbox, especially in 2011, led to any type of clinical improvement. But I just thought that it was kind of interesting that they said, well, you know, it's okay, you can continue your disease-modifying therapy unless it's too expensive. And you know, and we're gonna put the caveat around there that, you know, we know that none of these medications can improve anything, but since it's not improving anything and it's so expensive, we'll make the exception that, you should probably think about stopping this if you haven't seen anything after 2 years, right?
Yeah.
Kind of interesting how we've sort of changed our thought process around some of these.
Yeah, all good points. Thank you. The paper then went into a discussion about the ethical considerations. And I won't belabor these points too much, but they basically discuss these 3-4 words about the importance of these bioethical principles of autonomy, non-maleficence, and beneficence, with obviously autonomy ranking as the most important. And they also discussed the important role that clinicians play to give meaningful objective information. In the context of DMT discontinuation, I think this paper helps really shed some light on this really important topic. And they also talked about this concept of beneficence, or HCPs, doing good through their actions. And they further discuss about the possibility of DMT discontinuation actually bringing about good for a given patient. And so this is obviously an area of research, and precision medicine in particular, that we just don't have a lot of good answers for at this time. And then the authors discussed this non-maleficence topic, or not doing harm to patients, and how there has to be a balance in clinical decision-making between these two potentially competing topics of beneficence and non-maleficence. And then they finally made comments about how clinical decision-making in regards to DMT discontinuation is a moving and also an individualized target. So,
well, that's an important point, John, especially in the lack of, randomized controlled data that's substantive in any way. And I do have a couple of questions that have been coming in here as we talk, but one of them in particular kind of gets to this point. We had someone ask, in a patient who has primary progressive multiple sclerosis and is on ocrelizumab, if there was no clinical improvement for 2 years and at baseline the patient was paraplegic, when do you stop? And I think that brings up a couple of questions. I think one, again, going back to that concept of, do we really expect to see clinical improvement? I don't know that that's a realistic expectation, especially if a patient's paraplegic at baseline with a primary progressive MS. But it really gets to the point of non-malfeasance with respect to what's the risk-benefit ratio, right? So if we're going to substantially or potentially increase the risk of infectious complications in a patient who really isn't ambulatory or might have other medical comorbidities, what's that risk-benefit ratio look like? And are we doing the patient any good about continuing a medication where they might actually have some complications, whether it's infectious or not? And certainly that's one of the things that we often consider with any of these DMTs, but with ocrelizumab itself. Do you have any additional thoughts around that?
Yeah, no, all good points, Brian. I would say that the answer to this question, we'll likely actually get answers to this. And so there is a ongoing study called Oratorio Hand looking at the effects of ocrelizumab as it relates to upper extremity function. And for those of you that follow Dr. Giovannoni, either on his blog or on Twitter, he has this hashtag called ThinkHand. And I think traditionally, and I'll include myself in this bucket, we see these patients that come in who are paraplegic, and it's like, well, the effect of our disease-modifying therapies, as is already evidenced by the numerous studies that we just looked at, is likely not very high. But is there an opportunity to preserve upper extremity function to allow these patients to have best quality of life and perform their ADLs as best as possible? So we will get some answers on this, but there's just not good data right now to answer this question.
Yeah, but I think that it is, again, to your point, John, exciting that we're starting to capture this and really have a good handle on this, so we can have a better informed risk-benefit conversation with the patients and help drive those decisions, which in a lot of cases are as much as the patients as it is ours with some of these cases.
So the discussion section of the paper described this paper as comprehensive but not exhaustive, as a review of evidence and practice guidelines, as well as ethical considerations in the context of DMT discontinuation. As I mentioned earlier, only studies with greater than 10 cases were included in this particular analysis. And the practice guidelines and reimbursement policies that emphasize only EDSS cutoff criteria, according to those various Canadian provinces that we looked at, were only based on EDSS cutoff criteria. There was not age, gender, pre-treatment disease activity, all the other factors that we think about when we're potentially considering keeping a patient on therapy, or maybe even considering discontinuation. The authors discussed the importance of patient choice in the decision-making process, and with the highest respect going towards patient autonomy. And in the setting of limited evidence, there's this clear shared decision-making role that was highlighted, discussing the important risks and benefits of potential drug discontinuation. And the authors also highlighted the importance for prospective research with acknowledgement of a trial called the DISCOMS trial, so discontinuation of DMTs in MS. And so I actually went to clinicaltrials.gov to look at this. There's 7 centers involved in this study, and the goal is to determine the safety of stopping various MS disease medications versus continuation. And so the nice thing is we're going to get some really good data from this study, with hopefully trial end by February 2022. And it'll be a prospective randomized study of about 260 patients that'll be followed for over 2 years, who are 55 years and older. And so these patients have to meet the following clinical or radiographic criteria: no relapses on DMT for the past 5 years, and no MRI activity on DMT for the past 3 years, with the primary outcome of looking at the risk of relapse or new MRI activity for groups that are discontinued or groups that are continued on treatment. And of course, there's some secondary outcomes with MRI and EDSS as well. So hopefully this will be a really landmark study that will allow us to have a better gauge as to what drug discontinuation looks like, and all MS DMTs can be included in this particular analysis. And so this is the final formal slide here, and the authors stated that in the absence of strong evidence on when to discontinue DMTs, the shared decision-making process and consideration of the ethical complexities may assist in the decision-making process and also guide future research directions. So, Bryan, I think there's a few more questions that came in here into the chat box.
Yeah, absolutely. So, so great summary there, John. So we can talk about some of the questions that have come in through the chat function here, and then I think we're going to try to open it up to some of the folks who are online or on the phone as well. So let's take a stab at a couple of these questions before we open it up a little bit more. Catherine asks, in the Italian cohort 2015 study, the discontinuation DMT study after prolonged relapse-free period, was there a correlation of increased disease activity with what agent that they were switched to? And if I recall correctly, they were matched for age, sex, disability as defined by EDSS, and disease duration and time on treatment, but I don't recall that they were matched with agent. And
that's correct.
And I don't know if was that correct?
Yep, that is correct.
Okay. Yeah. I'm sorry. That was the MS-based cohort. I'm sorry. The MS-based cohort. They were matched to those variables, but I don't remember that they were matched to DMT. Correct.
That's right. Mm-hmm.
Yeah. Okay. Let's see, we have another question by our esteemed colleague from Chicago, Amy Perrin-Ross. Hi, Amy. Hope you're still online. What are your thoughts on the development of T1 black holes after stopping? And so that's a good question, right? And so I don't know, John, if you want to comment on this. I have some thoughts as well, and I'm sure others have thoughts. But so we have somebody who's on a DMT. We say, okay, well, we're going to stop, and part of the stopping that we've discussed across multiple studies and these guidelines also are continuing monitoring and continuing monitoring with MRI scans. So if we continue to see development of additional T1 black holes after stopping, what would you think about that? What's sort of your take on that?
Right, and in one of the Tysabri discontinuation studies, this was seen. And to me, it suggests an ongoing neurodegenerative process, despite the fact that clinically, perhaps his patients maybe weren't responding appropriately to natalizumab. You're still seeing the neurodegenerative process continue on. If that's what the question is related to, that seems to make the most sense upon discontinuation of natalizumab in that small cohort.
Yeah, I agree, and I think, sort of from a clinical practice standpoint, even folks who are on a DMT longitudinally, if we're looking at them over 5 years, over 8 years, over 10 years, do those areas translate into corresponding T1 black holes, and then again, how does that translate to brain volume loss over time? And I'm not sure that we have a good answer for that. I don't think anybody's really done a deep data dive on longitudinal MRI studies, but I could be wrong. I'm not an expert on that. If there's someone who wants to chime in on that when we open things up, that'd be great. We would really appreciate that. Great. Okay, let's see here. Okay. We've got another one here from our friend here, Amy. In light of COVID-19, has your stopping decision-making changed in older, less active patients with possible comorbidities? So, Amy, I'm assuming that you mean maybe someone who was a little bit older in age. Again, as we define older, it kind of varies by our our own age. But we have someone who's a little bit older on a DMT, maybe for a longer period of time, no real disease activity for a while, but they possibly have comorbidities such as hypertension, hyperlipidemia, heart disease, lung disease, maybe obesity, maybe some other things that have been identified as issues that could be placing someone at a higher risk for COVID-19 or COVID-19 complications. And does that sort of change our decision-making with regard to possibly stopping a DMT? John, do you have any thoughts about that one?
I think it's a really important question, and I think that, again, because we don't have good data even now, my personal opinion on this topic is that it depends on the disease-modifying therapy they're on. I mean, the reality is that there are S1P and interferon trials going on right now to look and see if these therapeutics might actually be beneficial. And so, you play these mental gymnastics in your head thinking, well, maybe one of the S1P drugs or the interferon drug might have some sort of protective effect in the setting of COVID-19 infection. So I think, for me, it really depends on the underlying agent that they're on, and also just trying to give patients the best data that we have available right now, which is really not a whole lot. There have been some publications, one out of New York, and of course the COVID-MS project that's ongoing, and hopefully all of us are adding cases as they come in. But we just need more data, and it's just such an individualized approach is the way I have been moving forward with patients.
Great, excellent.
Hey, Brian,
so,
what about this first question at the top here?
Yeah. So I was actually going to get to that. So someone brought up a case scenario. So a patient who is in their upper 60s, 69 years old, has been on an injectable interferon beta-1A since 96. So for quite some time, no relapses for 15 years. And so the question is, very low EDSS, high functioning EDSS is about 2 or 3. So what are the chances that that patient would have a relapse if they stop their interferon therapy? I have some thoughts about this, but let me get your thoughts.
Yeah, this is a great case, and it brings up, I think, all the topics that we've been talking about here. And so I'm not going to claim to have the answers here, but I mean, to me, I'm not a believer in this concept of benign MS. I think benign MS is a very low percentage of patients. This patient might meet that criteria, and if there was no recent MRI activity in the past several years to go along with what looks like clinical stability, that I would certainly raise it as a possibility. But I think the patient input here is extremely important. If they're adamant about not going off, fine. If they're adamant about going off, again, in the setting of radiographic stability, I'd be okay with that too, and do close clinical and radiographic monitoring over time. What do you think?
Yeah, and Hugh and I were sort of talking about some of these possible scenarios, and this was one of the scenarios that came up. And in medicine, sometimes we think about we're only as good as the last patient that we saw, right? And what were some of the times and experiences that we've had when these situations presented themselves? And I think, like you said, it's a high degree of variability. I've had patients who have actually been in their early 70s, and they were on an injectable DMT for a very long time, and at the behest of the patient, they say, hey, look, I'm just tired of giving myself shots. What are some of my options? And one of the options was, well, let's discontinue the medication and see how you do. And we agreed on 6 months as a time frame to get an MRI scan, and lo and behold, at that 6-month time period, they had multiple new T2 lesions. And you say to yourself, wow, why? How did that happen, and why did that happen? And then the question is, well, do you restart them? And if you do restart them, do you restart them on the DMT that they were on, or do you switch them to something else? But then we've also had patients who fit this scenario, and we stop them, and we might do serial MRI scans for a while, and they're rock solid, stable, and not much change at all. And so I think with a disease that's so phenotypically different, the best that we can do is make that informed decision with the patient, like you said, and do our due diligence and do the monitoring that we need to do, both clinically and radiographically, to ensure that we're not missing anything. So, John, I think, let's see, there's another question that came in around changing MRI scans and exam timeframes, every 3 months or how many months, and that they came in from Mary Kay, and I think there is some variability in there, Mary Kay. I think certainly seeing the patient more frequently, more often, having a tighter communication, closed-loop communication with the patient, and nowadays we're able to do that maybe a little bit better with telehealth, so that they don't have to come into the office per se, but maybe we would go ahead and get an MRI scan a little bit sooner. We generally do 6 months for the follow-up, but it might be acceptable to split the difference and do 3 months, again, depending on the patient.
Agreed.
Great, John. So we're at about 9 minutes before, and so I don't know if Kevin from Incom, if there's anybody on the phone lines that would want to ask some questions. But John, if you're okay, I don't know if we want to open it up and see if there are any other additional
Sure.
questions that are out there.
Absolutely.
All lines are now live on the phone. If you'd like to ask any questions, your lines are now live on the phone. Once again, all telephone lines are open, or you could ask a question by typing it into the Ask a Question feature on the left side of your screen.
John, I got another good question here around MRI scans from Kathy at the VA, who asks about the importance of brain volume by MRI scan. And I don't know if in your shop you use any particular brain volume averaging software, whether it's Lesion Quant or if they do any other type of brain volume averaging. I know that there's always some question as to what's the best way to do brain volume averaging, but is that something that you're routinely doing with your patients, or sometimes, or how are you approaching that?
Yeah, it's really an interesting topic. You know, from what I've read and talking with Dr. Rohit Bakshi in Massachusetts, I mean, these techniques that are done obviously have to be done at a center that has the capabilities and the processing capabilities to look at these images. And I don't have that at my institution, but I do know that the problem with measuring brain volume is highly variable, and it can be even variable among individual patients. And I remember a study that was published several years ago. These poor German grad students were literally, well, obviously voluntarily, but they were dehydrated. They chose voluntary dehydration for 24 hours, and they measured their brain volume. And then they did a huge 2-liter bolus of fluid, and several hours later scanned their brains again. And the difference in brain volume was dramatic. An entire year's worth of brain atrophy was seen. Obviously, that was a pseudo-atrophy situation, but just based on hydration status. And so there's so many variables that, you know, outside of a center that has such expertise or randomized phase 3 trials, I find it personally hard to look at this data and make individual patient decisions regarding treatments.
Yeah, so yeah, I agree, you know, and part of that is looking at what you're comparing it to, right? So if you're able to compare the patient to themselves, whereas you have longitudinal data and you've been reliably using the same metrics, then I think that that's helpful when you're looking at some of these comparison data sets to quote-unquote age-matched controls. You know, I'm not really sure what we can make of that. But again, even when we do that, using that longitudinally would be helpful, so you can track that same patient against those same controls over time. You know, part of it is with regard to reimbursement, and I understand that some payers, including some CMS plans, have been able to pay for that extra step in the radiology exam, and some have not. I think that it would be important for us to, if we are going to do it with a given patient or a patient population, to be consistent around it as best as possible.
Yes.
Good question. Hi guys, this is June. First of all, terrific program, but one last question, or a question I have. Would ethnic background come into any kind of your decision-making process in terms of, we know what's going on with COVID now, and we really don't know the real story, but we know people of color are not doing well. We know people of color had mixed reactions to DMTs. If you have a person of color on a DMT, will their ethnic background cause you to reconsider or think differently about a stop?
Yeah, this is a really important topic here, obviously, June. I mean, I'll take a stab at it, and Brian, I'm curious your opinion too. I mean, I'm always concerned about patients of color and drug discontinuation for any reason. And so I personally would be less eager to consider drug discontinuation in a patient of color, frankly, even if they're older and they're tolerating the therapy well, they're clinically and radiographically stable. I would have significant reservations about pulling that patient off if all the other clinical and radiographic metrics are in line with stability.
What do you think, Bryan?
Yeah, I agree, and in the lack of some other data that we just don't have, I think, you err on the side of caution. I'd be much more inclined to, as long as, again, we're not doing any harm, to make sure that patients are doing well from an MS standpoint, right? So the question is, brain is optimal tissue, and we don't want to disrupt that whatsoever. And so I think it's going to be important for us to do no harm first. And certainly, as bad as COVID is and the complications that COVID can be, so would a brainstem lesion. If we were to inappropriately switch a DMT or discontinue a DMT, and I think the unpredictable nature of this disease and the phenotypic variability of this disease makes us be a little bit more cautious. So I agree with John. Yeah.
Yeah, I mean, it's a complicated situation too. Our country, particularly, may be different in Europe, but we have such a mixed population here. It's a challenge, I think, and it's not easily these decisions are not easily made.
Yeah, absolutely.
Absolutely.
Well, you guys did great. Thank you. I'm going to log off.
Yeah, thanks, Jen. We greatly appreciate it.
Jen.
We're at the top of the hour, and certainly we want to be mindful of everyone's time. I think this was a great conversation. It was a great article. Thank you, John, very much for steering this, and very, very helpful. I'm always available for additional comments and questions and follow-up, and we'd love to hear from you. So please reach out if you do have any other additional questions or comments. And this is your forum, and if you think that this is value added and that you're getting something out of these journal clubs and in these discussions, please let us know, and whatever we can do to make it better, then please let us know about that as well. John, any closing comments or thoughts?
No, that was great, Bryan. Thanks so much, everybody, for joining us here. I know it's late for some people on the East Coast, so look forward to everybody joining on the next one, which I think an email will be going about that in the near future.
Thank you.
Great.
That does conclude tonight's teleconference and webinar. You may disconnect your line at this time and have a wonderful evening. We thank you for your participation.